Okay. Hi, everyone. Again, thank you so much for joining MVC's Health in Action Work Group today. My name is Erin Conklin. I am the program manager for the Michigan Value Collaborative, and I look forward to facilitating today. In recognition of Sepsis Awareness Month, today's Health in Action Work Group will feature a presentation by Tami Garcia, Carly Redstone, and Rosalie Mulcahy, and also Jesse King from the University of Michigan's Michigan Medicine's Quality Department Sepsis team. We will also focus on helping care teams identify sepsis early and act quickly to stop sepsis and save lives. Just a little bit of background on our presenters today. Tami Garcia serves as the Sepsis Program Process Lead. In her role, Tami provides oversight to the operations of the sepsis program. Tami collaborates with the sepsis coordinators to identify barriers and educational gaps for frontline staff. And also she assists in developing policies, procedures, and standards, as well as implementing and assessing quality improvement initiatives. Carly Redstone serves as the Adult Emergency Sepsis Coordinator. In her role, Carly provides education to the emergency department staff about early identification and treatment of sepsis. Additionally, she identifies and addresses barriers to ordering and administering life-saving interventions and supports staff with the use of embedded sepsis alerts and order sets in MyChart. Rosalie Mulcahy serves as the Inpatient Sepsis Coordinator for the adult hospitals at Michigan Medicine. In her role, Rosalie is responsible for facilitating evidence-based practice in line with current sepsis guidelines, providing education to clinical staff, and performing chart reviews to identify areas of opportunity. Dr. Jesse King serves as clinical assistant professor of internal medicine. Prior to professorship, Dr. King completed medical training at Albert Einstein School of Medicine and at the University of Michigan Health System. Dr. King also serves as medical director of Michigan Medicine's sepsis initiatives, the respiratory clinic, and the ambulatory and diagnostic units. Thank you to Tami, Carly, Rosalie, and Dr. King for joining us today for this work group. Before you begin your presentation, I just have a few brief housekeeping items to review. This session is being recorded. Slides and the recording will be shared with attendees following the work group. We will be monitoring the chat throughout the presentation for questions, so feel free to add any during that time. And we will also have time at the end for folks to ask questions. Additionally, your feedback is important, so please complete the post-work group survey that will be sent in the email following the work group. With that, I will turn it over to our presenters to lead us through the discussion today.
Great. Can we, go to the next slide. So as you so kindly introduced, I'm Jesse King, and I'm the physician with an official title in the quality department as medical director for sepsis initiatives, right? So I actually was here 3 years ago. I was invited to come and speak about some quality improvement work that we were undertaking at the University of Michigan around improving our sepsis outcomes. We had data at the time that showed that our sepsis patients at U of M had poor outcomes with regards to mortality, and those patients that did survive their sepsis event were staying in the hospital much longer compared to our peers. And so I sort of accidentally fell into the position of providing some opinions, is what I was asked to do, provide some opinions around, my role as a hospitalist and how we can improve these outcomes. So 3 years later, I now have an appointment within the quality department with dedicated effort. And we've actually made a lot of big changes. So when I was here 3 years ago, really I came to talk about how we were collecting our data, what metrics we were measuring, how we went about setting performance goals around both SEP1 compliance, so hopefully that you guys know, but SEP 1 is a bundled treatment for sepsis that you are supposed to implement as soon as you recognize your patient is infected. And then setting goals around outcomes around mortality and length of stay. During that talk 3 years ago, I highlighted 3 quality improvement projects, right? That's all this was a project around really finding early recognition and treatment of sepsis, both in the emergency room and in the adult inpatient setting. And also I talked about what we were doing to reduce readmissions, because we also had a remarkably high readmission rate for our sepsis patients. So we were doing we had 3 kind of parallel projects going on. There was also work being done on the pediatric side that I was aware of, but not involved with. It was very tangential every now and then. I talked to them every now and then, they talked to me, but for the most part, we had the right hand had no idea what the left hand or the pediatric side was doing. And so really, we talked about a lot of the sort of what we were doing to implement or improve our recognition and treatment of sepsis and prevent these adult patients from being readmitted. And what did we learn? Well, we very quickly learned that this is not a one and done quality improvement project. This is not, how do we get our patients roomed faster? This is actually was a huge undertaking. And at the time it was a huge undertaking that I was doing more or less by myself with a couple of quality improvement specialists and a couple of project managers. And what we really learned, or the biggest lesson that we learned, is that this work requires consistent, dedicated resources over the long term. So this is really going to be the story of how we obtained those consistent and dedicated resources, what that looks like, and how we're using those resources, which I say resources, wonderful, amazing people that helped me do this work. So this is where we started. So we actually started a couple years before that, but we did, we were looking pretty poor in terms of our SEP 1 sepsis bundle compliance. We had about a 37% compliance rate. And continued to struggle. It didn't matter how much I shouted from the rooftops that we needed to do the right thing around sepsis. Nothing was changing. And we, here we were at 37% compliance when, the national average was 60%, and those best performing hospitals were getting 80% compliance with their sepsis bundles. Our sepsis mortality index, so that otherwise known as the observed to expected mortality ratio, was 1.22. And so, being Michigan and the snobs that we sometimes can be, we had to compare ourselves to the other ranked top 20 US News and World Report hospitals. And we actually found that we were pretty poor. We were in the bottom quarter of that group. We were being outperformed by most of our academic peers. And what we really struggled with is that, as I said, it was me shouting from the rooftops and nobody paying attention, thinking I was the crazy lady on the roof. And I, went to various leadership people and I said, look, we're doing poorly. And they're like, yes, we're doing poorly. That's nice. And they kind of continued on. And so while there were quality improvement teams at work trying to improve our early identification and interventions in the emergency room and in the inpatient setting, I was really the only person tying those two groups together. And I'm not an emergency room physician. So there was a lot of struggle. We were riding the struggle bus. It felt like we were putting in a lot of effort and not getting a lot of return coming back. So next slide. So what did we do? Essentially, I went to the quality department and I said, help, this needs to be more than me. And we came up with a strategy of how do we make this an organizational priority? So we essentially made the case with our executive leaders that we need to actually focus on sepsis, focus on our sepsis treatment, and we need to improve these numbers. We made this argument because sepsis was essentially the #1 discharge diagnosis outside of childbirth here at Michigan Medicine, and it was by far and away the leading cause of death in our hospital. We know that sepsis mortality performance is part of many, many different ratings that the hospital undergoes, and in order to maintain our ratings and not drop down in those ratings, we really needed to improve our performance. And then the other thing that we struggled with is that sepsis was really had the highest leading DRG for readmission. So even our heart failure patients, which tried to give us a run for our money, didn't have the readmission rate that our sepsis patients did, both our 30-day and our 90-day readmission rate. And the other part of this, is really thinking about how do you get to the executive's heart, right? It's through their wallet. And so we talked a lot about also, length of stay. So, I recognize that all this data that I'm showing on the right is really, really tiny. But if you look at the graphs in the bottom right corner, this is our 2018 data, looking at length of stay for severe sepsis and septic shock. So not simple sepsis. And for those patients who received ICU care, on average, they were in the ICU for about 9 days, 9.1 days. But if they got their SEP1 bundle, that was reduced to 6.7 days. And their overall length of stay within the hospital for our severe sepsis and septic shock patients was 2.5 weeks. So it was 17.4 days. If they got that SEP1 bundle, it was down to 11.7 days. So we really showed them these are patients sitting in our beds for 2.5 weeks, right? That's occupying a bed that we need, because I'm sure you guys are experiencing also those backlogs in the emergency rooms and so forth. So really talked about, length of stay, cost of stay, and cost of caring for these patients, and then cost of caring for their readmissions, right? And really trying to get the attention of our executive leadership. Long story short is they started paying attention and said, oh no, okay, how do we fix this? So we came up with a proposal for what we called, with our lack of imagination, the sepsis program. Next slide. So here was our argument and our message to executive leadership. Is that, as I noted, sepsis was our highest volume DRG, and it is the largest driver of inpatient mortality in our patients. We had observed sepsis mortality, lengths of stay, and readmission rates that were far and above higher than our peers in terms of the expected for each of those. And that when you looked at our risk-adjusted data, our own data supported the use of the SEP1 bundle and SEP1 bundle compliance in reducing that mortality and that length of stay. One of the major challenges and an argument for the sepsis program is that while our patients who have heart attacks are owned by the cardiology group, and our patients who have strokes find a home in neurology, those sepsis patients are occurring anywhere and everywhere. They are across our institution. They are on the ENT service, they're on the physical medicine and rehab service, they're on the surgical service, and there's plenty of them on the inpatient medicine service, right? So unfortunately, we could make the argument, oh, they're owned by the critical care people, except the critical care people actually only see a small portion of these patients. So there was no ownership, there was no house in order to own and operationally own sepsis patients. And as I kind of noted, we had unfortunately an environment in which our sepsis recognition was poor, that sepsis was not treated as the medical emergency it actually is. And when you talk to staff, their knowledge of the sepsis bundle is poor, and a lot of them had arguments around the data behind the sepsis bundles. And so there's a lot of special snowflaking of their patients. Everybody's patient is a special snowflake. There's a reason not to comply with the sepsis bundle. And by the way, the data behind them isn't good anyway. So these were really our arguments about why we needed to really develop a program around sepsis, is to improve our recognition, treat sepsis as the medical emergency it is, and really get our providers following the national guidelines when it came to care. So we put in what we at University of Michigan call an SBAR, but essentially it was an argument or rationale behind why the sepsis program was needed. And we, as I said, the way to the executive's heart is through their wallet. So we partnered with finance to really determine, develop a return on investment of having our program. So we based this solely on very conservative improvements in bundle compliance. We limited our analysis to those patients with severe sepsis and septic shock, so the sicker of our patients who present to our facility. And we argued that if we improve bundle compliance and we decrease length of stay by 1 day, it would pay for our proposed sepsis program 2 times over, right? So that was our argument behind the sepsis program, and they bought it. They were willing to invest. So this is what we proposed in terms of FTE, or full-time employment. So up at the very top, there were at the time 4 physician champions recognized, or the recognition that we would need to give effort for at least 4 physicians in different areas of the hospital in order to champion this work. We proposed 10% effort to be given to our pediatric sepsis champion. We proposed 10% effort to be dedicated to an ER physician, as obviously a significant portion of our patients are presenting to the emergency room. And then given we also have, while much lower rates of sepsis in our OB population, those patients, when they get sick, tend to get very sick. And so they're actually proportionally a higher utilizers of our ICUs. And so we also made the argument that there should be at least a 5% effort for an OB champion in order to support the work across the institution. We also drafted narratives for incremental FTE. So these are new hires to take place to staff and be our sepsis team for the institution. So this included 3 sepsis coordinators. We have 2 adult sepsis coordinators, 1 dedicated to the emergency room and 1 dedicated to everybody else. So, maybe not an equal divide. And then 1 dedicated to our women and children's hospital. So we have a separate sepsis coordinator that does our pediatric and obstetric work. We have a sepsis process lead, who is Tami, who will also be speaking with you, who like me is somebody who bridges all 3 programs, right? So we need the left hand and the right hand, not only to know what each other is doing, but to actually talk to each other. So we have somebody who sort of has her fingertips in all 3 areas and understands what's going on across the institution. And to really build a sort of a programmatic theme so that we don't have mismatched messages in different areas. And then the other major contribution was what we have in here is called a Sepsis MyChart Builder. So we, as a quality department, are paying for an employee in our computer group, in what we call our HITS department, which is in our informational technology. So we have a dedicated MyChart builder that is actually a member of our team. And that's been fabulous because he also spans all 3 separate areas and understands the workflow and how patients pass from the emergency room into the inpatient to the ICU and so forth. We also proposed, but ultimately did not get 20% administrative support. So unfortunately, we are still working. We use one of our supervisors, administrators when we need administrative support. But the MyChart builder, I think, was more important than that administrative support. In terms of administrators, these are unfunded positions. So these are people who already have positions in quality and safety in the adult hospital and the pediatric hospital, who a portion of their work would now be dedicated to supporting our team. And then we also have some unfunded institutional positions within our data analysis group. So quality analytics is a subgroup of our quality department. And so we have people that we can tag to help us with data management and any data questions we have. So this is what we proposed, and we got, with the exception of the administrative support, we got pretty much almost everything we asked for. Next slide. And so this is how we sit. So the key here is that we interact with the entire hospital. I don't think there's a group in the hospital that hasn't touched us at some point. Because we talk to everybody. Obviously, we have the data people and the quality improvement people, We talk to, nurses, Office of Patient Experience. We talk to our patients. We have patient education. We have resident education. We have physician education. There are so many different areas that we touch across the entire institution. And then we as a team work together. We parallel report to our adult and pediatric safety and quality committees. So we report out to them on a quarterly basis. And then we also report up to our sepsis executive committee, which is a hospital leadership, as well as the clinical quality council, which is the overarching clinical quality group. And then obviously all the way up to the hospital board. So this is kind of how we see ourselves within the structure of the institution. Next slide. And this is kind of how, the problem is that here we touch every part of the hospital. We also live in several different segments, right? So this is another version of our reporting structure. So, we have one sepsis coordinator. She lays within the Department of Quality, but also, but then works within the reporting structure of children's and women's. Same with the adult hospitals. So those yellow boxes are our incremental hires, our incremental FTEs as part of the program. So those are our sepsis coordinators and their reporting structure within their silos, right? So. And the major win is that we were able to get our sepsis Step 1 bundle performance as a safety and quality big priority within the institution. So now it's not just me shouting from the rooftops, but now I have the president of our hospital also shouting from the rooftops that we need to improve our sepsis care, which amplifies my voice quite a bit and our team's voice quite a bit. So we were able, there were some delays in sort of getting the team up and running, but we were able to make ourselves part of the what we called our base priorities, or the S for safety, as part of our priorities within the hospital. Next slide. All right. So in about September of 2021, we got the rubber stamp to go ahead and approve all of our incremental FTEs. We went about interviewing and hiring our sepsis process lead, as well as our sepsis coordinators. And then the final member of our team was that computer person, who we call our HITS person, who joined our sepsis team actually approximately a year ago. So we've been as a group together for a year. Next slide. So I'll leave it to Tami to kind of talk about what our work looks like.
All right, thanks, Jessie. Like I said, like Erin already introduced me, I'm Tami Garcia. I'm the sepsis process lead, and I get the pleasure of working with all the coordinators in all the hospitals, which has been very fun. And I have a great group with us here today. So Jessie's already explained this, our team, but we do have Jessie as our medical director. I'm over all the coordinators working with them. Rosalie Mulcahy is in our inpatient adult area. We have Carly Redstone in our adult emergency services, and Sarah Pulley. She's here. I think she's on the meeting here today, but she's in our Mott Children's Hospital and our Von Voigtlander Women's Hospital. And Andrew Guttering is our sepsis HITS person that we talk about a lot, which has been a great addition to our team as well. So we formed fully as the four of us as coordinators at the end of March of 22, and then Andrew joined us in October of 22. We came in with a lot of work that had already been done, like Dr. King has already explained, but really we didn't have, they had set out some goals for us, but we were a new program. So we kind of came and we had to find our way and figure out how we were going to create our roles and make them work. So we also, being part of the quality department, we have access to many resources. And so we have a great continuous improvement program and specialists that we worked with. So we got together and said, okay, why are we here, right? We knew we were told we have a problem with sepsis and we need to do better. So but what does that really mean? And how are we going to tackle it in all of these areas with so many patients and service lines to get education to and make improvements? So really got together to define our roles, what we are going to do, and really looking at the vision of the program, the sepsis program that, Dr. King and all the others had kind of put in place for us, and what that vision is and how we're going to create it and continue the work that they had already done. And really thought, and we really wanted to be intentional about how our team would function, and really looking at our goals, roles, processes, and our interpersonal relationships. Because if we don't have all of these things defined before we start, we knew we were going to have a problem because we had a lot of work to do. So we really got together and we talked about clarifying our goals and creating those goals, looking at what our roles were and what those key stakeholders were, who we needed to report to and who we needed to talk to about barriers, and really looking at our frontline staff, the ones who are doing the majority of the work. So we started developing some team processes together. And then really after that, after we had the goals, we did some continuous improvement work. We worked through some A3s, but really the biggest part of our work in the last year, our first year, I would say, is really we had to go out and meet our teams, walk the walk, walk the gamba, and learn from our staff. What really is the current state of sepsis at Michigan Medicine, and how is our team going to help work with the frontline staff to make this work possible? So after a year and a half, I would say, this was just a snippet of what we do, I feel like, or the coordinators do, and they can help me with this later. But really, what do we do? What is our role? What is a day in the life of a sepsis coordinator at Michigan Medicine? A lot of our work is really looking at patients. We're in our EMR looking for our sepsis alerts. There's a track board in our adult emergency services that we're looking at current potential sepsis cases. And really part of our job, which we think is the most important, is really giving that at the elbow guidance and feedback to our teams, being there, making them think about sepsis, helping create a culture of that being part of their differential diagnosis. So really, I would say probably one of our favorite parts of our job is rounding on the units with our staff, spreading awareness, talking about the patients, really diving into charts and keeping our clinical skills where we want them to be so we can help them learn and grow as staff and treat and identify patients with sepsis earlier. We also follow up on cases, maybe from the day prior or over the weekend. We like to provide feedback to our staff, as real time as possible in the form of kudos and opportunities, which we've had great success with, both in just awareness of sepsis and giving recognition to our really, tired and overburdened staff right now. We also get safety reports that are sepsis related that we have to look at and make sure. We like to look at the trends there and follow those and think about action plans surrounding what our next steps are with our teams. We have a lot of committees that we have formed and give updates to. So we do a lot of meeting plannings, creating agendas, meeting minutes, and action planning with those teams. And that's really looking at the stakeholders and looking at barriers with those teams and how they can help us engage teams and make us be successful. We do a lot of educating. So we weren't handed an education plan, but we had to actually create some curriculum. And again, that was after we did the GEM, but we had to go and find out where our units were at in their education. We have a lot, as you all know, we have a lot of staff turnover. We have a lot of novice staff. So we really have been going back to the basics and creating plans for our staff that are appropriate for where they are. And we have made some things virtual as well, so that since we can't hit everybody, that we have education available. We also have a lot of data at Michigan Medicine that we watch in our sepsis dashboards that we look at trends, and then we like to report that out to staff. We do goal setting with our teams and with our individual units on bundle compliance. And then also, Andrew, right? We're working with HITS to make our Epic tools for our frontline staff more readily available, easier for them to do their job. And then also a big part that we need to tackle a little bit more is planning and providing education for our patients and families. So really, that kind of summarizes what we do, even though, like I said, I feel like it's a lot more than that. We feel like we're busy most times working with our staff. Looking at our adult emergency services department and Carly Redstone and looking at some wins. So what have we done over this last year and a half that we feel like we've been really successful? And I would have to say, you know, thinking about the Gemba, what we've been doing, listening to our teams, listening to their barriers, looking at their workflow, right? We have a lot of capacity issues and workflow issues that we're working with daily, and learning from them what we can do to help them, and really learning about the culture surrounding sepsis identification and treatment. We're trying to dispel some myths about sepsis and really just getting people to say, hey, is this sepsis? That's really what one of our catchphrases is. Carly really has done a great job. She really has walked the walk, talked the talk. She really has dove into learning what the staff need from us. And really listening to him, and you know, backing off when she feels like she goes down to the ER and there's 60 patients waiting, then she kind of backs off and gives them some treats and walks back out because we know how busy they are. So really helping us learn from our teams. And then Carly has created some great education. We do a lot of at the elbow guidance and real-time feedback, and sometimes that's in person, and sometimes we do that through messaging through our Epic EMR charting areas, where we can do a secure chat with them to talk to them about their patients, because again, we know they're busy. And then really looking at our hits in Epic, we have a NIPCO, a nurse-initiated patient care order in our adult emergency services related to sepsis. And we really have, Carly has worked hard to re-educate on that and allow staff to use that, because I'll show you some data in a minute to show that when we use the NIPCO, that our outcomes are improved greatly. And really, like I said before, we're really just asking that staff consider and think about, could this be sepsis? So this is the data that I was talking about. These are patients that are coded for severe sepsis and septic shock with the time zero in our adult emergency services department. This was FY23, about 795 patients. Our NIPCO, we have a couple NIPCOs that we're actually working on combining at this time. That was another barrier that staff thought that it was a little bit confusing having both, that they were actually diagnosing. So we're just going to make one NIPCO, sepsis NIPCO. So we're working on that presently. But really what the NIPCO is, the severe sepsis NIPCO at this time is getting an ABG or VBG at 0 hour and then 4 hour for the lactate, a CBC, a comp, and coag panel, blood cultures ×2, a UA with a culture reflex, a chest x-ray. And then if there's a septic shock NIPCO, we have all of those orders, plus we add in that 30 mLs per kg LR bolus, ideal body weight if the BMI is greater than 30, a MAG, a FOS, and a portable chest x-ray. So what this data shows, as you can see, is with our 3-hour bundle compliance in the blue, when the NIPCO is used, which was 57.5%, and no NIPCO was 30.5%. You can see when we do use the bundle, when we go to the next area with the antibiotic timing, that this is in minutes. So when we use the NIPCO, we're at 129 minutes. And when we don't use the NIPCO we're at 184, with our goal target being at the 180. So we are doing better when we use that NIPCO, significantly better. And then just to the last area here with our mortality, also when we use the NIPCO, our mortality rate is 15.8%. And when we don't use the NIPCO, we're at 23.6%. So this has been a great success for us in the use of this NIPCO and helping the outcomes for our patients. And this is just more data just to show the successes of having the coordinator in our adult emergency services. It is kind of busy, but I think the colors are pretty. You can see that FY20, we were averaging about 38.7%. This is SEP1 CMS abstracted data for our SEP1 bundle compliance in our adult emergency services. You can see as we have gone along here, you know, FY21 was 39, FY22, 50.6. And the big yellow star there, that's where our team was formed, and Carly started doing her work down in AES. And you can see that we have actually increased our bundle compliance up to an average of 58.2%. And I just want to make note that in this last June, that we were at 76.7%, which is one of our highest compliance rates. And this again is just showing the 12-month average of our SEP1 bundle sepsis compliance. And you can see again, we are our 12-month average, we're at a 58.5%, which our target was for greater than 55%. And in June, oh, sorry, I misspoke when I said June, as July actually was our highest of 77.8%. Again, this is just showing, these are the patients that were time zeroed in our adult emergency services. Again, so just very successful in our outcomes as we've had our sepsis team and Carly working down in our adult emergency services department. So in our inpatient area, we have Rosalie Mulcahy there. She has been doing a lot of work as well. It's a big area that we're trying to conquer. Everyone calls it the beast because there's so many service lines that we're working with and so many staff members that we're trying to touch. But Rosalie has been doing a wonderful job. She has really gone and walked the Gemba and learned our current state of affairs and our culture on those units, really listening to staff and really coming to the staff with what they need and what they've told her, and looking at their barriers together and what really is going on. She is also providing education at the elbow. She actually has a book of education that she walks around, and she's now approached, hey, where's your education? I feel like staff now know her as the sepsis lady. We have a lot of novice nurses on those units, and I think they're just eating up everything that they can give, that she can help teach them and learn about sepsis and sepsis care. And that's providers, and like she shamelessly goes into provider spaces and it says, hey, I'm Rosalie, what do you want to learn from me? And I feel like they eat it up all the time. She has started a sepsis champion program in our inpatient area in the last couple months. We've done a lot of also work with some best performing hospitals to kind of see what they're doing that is working very well. And so one of the things that we found that you know, there's only 4 of us and we have a lot of people that we need to touch and provide education. So we need to train some trainers, right? We need to get some other people that are boots on the ground that can be there 24/7 to help us spread this word and help care when we can't be available. So we looked at some high volume, kind of highly engaged units. And so we started there and we've been quite successful with that work. Now we have people asking, hey, we need some sepsis champions. Can we do this work? So we've added a couple more units. So Rosalie's working very closely, again, with our continuous improvement program, because trying to create curriculum and organizing and keeping it all together has found to be very tricky and very engaging and overwhelming. We've also done a lot of work with provider engagement, you know, really getting providers to jump on board with us is hard. Like I said, there's so many services, and really validating the data with them to show them, hey, we have data to support that when we use this bundle of care that our patients do better and we need to do better. And really learning how we can have access to educating and giving them feedback. And so we've had some great successes lately with getting some engagement from our providers. And then again, looking at our HITS and EPIC tools, what's working, what needs to be changed. We have a lot of I think the first conversations we had many times was, you know, our BPA alerts were over alerting and how can we help them out. And so we've done some great work there to help reduce our BPA alerts to our teams. And really thinking about what tools do we have. We don't want to create more work for teams, right? They're not going to do anything more. They have enough going on. So what can we do to help make their workflow easier and then help them identify and manage these patients quicker? So that is our story, so to speak. I feel like we've been pretty successful in what we've done. I look forward to all of the future work that we're going to be together, and I think now we're going to open up for questions.
Thank you so much. And yes, folks on the call, what questions do you have for the Michigan Medicine Sepsis team? I'll get us started because I have one. So, you kind of have shared about your working across Michigan medicine, both from an adult and children's perspective across multiple service lines and things like that. Could you talk through a little bit about a communication strategy, if you had a communication strategy for how you kind of approach this, if you had one at all?
So I will tell you, we kind of made it up as we went along to begin with. Just because, as I said, the work that was being done on the pediatric side actually preceded the work that was being done on the adult side. So they were a little bit ahead of us. I think there's also a different spirit of quality improvement and safety on the pediatric side than there is on the adult side. Just because on the pediatric side, they're improving for improvement's sake, for their patient's sake, right? On the adult side, we improve because CMS says we have to, right? And a lot of it is like, how do we play those numbers? How do we play those games, right? So in fact, the peds folks were actually ahead of us in a lot of ways than we were on the adult side. And so, they were also a lot more open and inviting to our sepsis coordinators and ready to talk to them. And I guess Sarah can correct me if I'm wrong, but, for example, she went to the pediatric residency program and was like, I want to show up once a month and talk to you guys about sepsis. And they're like, yes, come on in. And we went to the adult internal medicine residency program, and we said, we want to come and talk to you about sepsis. And they're like, well, you can have 15 minutes in February of 2024. And we're like, okay. So, I think, and in some ways, I think that there's, at least at the beginning, there was a lot more leadership support on the pediatric side than there was on the adult side. So which is evolving and improving, but that was definitely a big struggle to begin with. I was like, look how easy the pediatric folks have it, because just that spirit of improving for safety and patient sake existed on their side much more so than the adult side. So I think, by now a year in having a program and having people who are in touch with all of those different areas, and the fact that, our coordinators share an office and can talk to each other, right? Like, sometimes I'll be talking to Rosalie in a meeting and Sarah will be in the background sitting at her desk, right? So I think that there's much more collaboration and coordination among our groups, and a lot more discussion about making sure that the messages that we are sending out are being received and are coordinated. So, yes, as Sarah put in her thing, she actually said, nobody likes a dead kid, but we can explain a dead adult, right? Which is a really, really harsh thing to say, but it's true, right? And I think that there's very different pressures on the pediatric side than on the adult side in terms of safety and quality. So those are, both barriers that we've had to overcome. And I think things are the areas of success of now we're sharing ideas and sharing messages. So.
Great, thank you very much. I see that we have a question from Joy. And Joy's question is, have you done any work with the topic of sepsis 2 versus sepsis 3?
So the short answer is no, because, and this is why, is our institutional providers, with the exception of our critical care docs, are, I will be honest, not up to date on their sepsis literature and not up to date on that they actually don't know. And so a lot of, and every now and then I'll get somebody, I presented at orthopedics grand rounds, and they're like, well, what about that, SOFA and the Q SOFA, and can we use that? And, and my short answer is, if by the time they're scoring high enough on Q SOFA, you're in trouble. For, my personal feeling is by the time you're scoring on QSOFA, you're in trouble and need an ICU anyway. And so, but honestly, the fact is that our providers I feel terrible saying this, but the vast majority of them are not up enough on the literature to even really recognize the difference and understand the literature. So really it came down to me coming to them with very basic checklists of this is the expectation for treatment. These are the organ dysfunctions that count towards organ dysfunction. Yes, there's, the SEP3 definition got rid of SIRS, but billing still uses SIRS, right? Like we're still using the old definitions for billing. And so, but most of them are honestly not savvy enough I feel terrible saying that. Not up enough on the literature to even ask with rare exception.
Thank you for sharing that. There is another question from Carol, and the first part is, how easy was buy-in from physicians and pharmacy for nurse-driven protocols? And then the second part of that question is, how long does it take for nurses to be comfortable with placing the orders independently?
I will take that. So this was already established. This is the longstanding practice in our adult emergency services. The sepsis NIPGO existed before I got there. There's happens to be two, and so we're working on kind of optimizing it for nurse use. I would say the way that it currently works is if the patient has, like 0 to 2 SIRS, and if they're screened as having potential new altered mental status or organ dysfunction, along with signs or symptoms of infection by the triage nurse, they'll get a prompt to order the sepsis NIPGO. We are only ordering that about 40% of the time. So there's a ton of improvement or opportunities, I should say, to really improve care for a lot of our patients that screen positive. On the flip side, given that discussion about SIRS, if a patient has normal-ish vital signs, even if they're suspected of having infection, we're trying to educate our nurses that they can still order that NIPGO. Most people don't come in and say, I think I have sepsis, unless they've already had it. But most of the time it's, my stomach hurts, I just don't feel good, I'm really fatigued. There's super vague symptoms. And so we're trying to get that, just because a patient comes in with abdominal pain, if you think that it's being driven by infection, to order the sepsis NIPGO. So that we still have a long ways to go in that. Most of our orders are coming only from like that prompt. And I would say that it is a lot of more of our experienced nurses who do feel comfortable. We're calling it the risk for sepsis NIPGO. I think previously it might have just said sepsis, and nurses felt it might be out of scope to diagnose. A lot of our other nurse-initiated care orders are based on more symptoms, right? Abdominal pain, flank pain, different things like that, shortness of breath. So having a specific diagnosis, can also cause some like indecision moments, and they don't want to do the wrong thing. So we're trying to very much get them, it's so much better to rule out sepsis than to not have the data to rule it in. The NIPGO does look a little lengthy, obviously during blood cultures on every patient that comes in, especially when you have 60 people in the waiting room, can be daunting, but we're saying you're already doing one blood draw, right? At least get your first set, move on. You can grab the second set once the patient's back in a room. So we still have a long ways to go, but in general buy-in was already very well established. I worked there as a nurse for almost 9 years, starting in 2012, and that was already a practice in place.
And I'll just add, we're working on an inpatient order set. We proposed the NIPGO and that quickly got turned down, let's say. So we had to change our verbiage with that. So we are tackling that now. We do have other order sets already in place in our inpatient area. And it's mostly in our hem-onc, like BMT patient population. They have an order set that they use. And the nurses seem to use it readily and don't seem to have we don't have a lot of resistance there. So we're hoping that we have success when we get our sepsis order set together for our teams.
What other questions does the group have for our presenters today? One other question that I have is, you talked a little bit about kind of engaging, a lot of key stakeholders, and part of them, or one of those groups, was patient education in the Office of Patient Experience. Could you talk a little bit about how you've engaged maybe either patients' voices or patients and families in the development and implementation of the sepsis program?
Ooh, Sarah, can you tackle this one?
I have to be totally transparent. I was distracted for a moment. What was your question?
No problem, Sarah. My question was, could you talk a little bit about how you've maybe engaged the Office of Patient Experience or patients and families kind of as part of the program development and implementation?
Yeah, so a lot of our Office of Patient Experience has been fabulous to work with. I have had some very complex sepsis patients. As you can imagine, our pediatric patient population here at the U has a niche of like congenital anomalies or the very unusual complex pediatric patient diagnosis, because we have the subspecialties to support those areas. And so there have been a handful of kids that have come through that have been in the University of Michigan system for all of their lives. And so being able to reach out to them, they're honored to be included in the opportunity to tell a story, or to be supported by the patient experience department. That has been very easy and nice to do. Oh, I can share my contact information, and yeah, so they have been super friendly, super helpful, right? So incorporating in pediatric medicine, we always think of the patient and the family as one, right? So in adult medicine, your focus is a lot on the actual patient, but all of like my education is for the patient and the family, and the patient and their support team, who is their family. And so patient care experience really, or the Office of Patient Experience really encourages, pushes, reaches out to the families, and really connects them with opportunity for support and hopefully improving that outcome, preventing sepsis again.
Thank you very much.
Yeah, and I will say that, on the adult side, we've, the Office of Patient Experience has, again, patients that are dedicated and willing to kind of help improve things. And so we have engaged them for certain projects or certain aspects of the work, asking them about, what is your opinion about this workflow, or, what is your experience in this setting? That's been very valuable to take into consideration, sort of the patient experience, and what we're, and what we see from is a very, very system and provider oriented, program. Yes, I want to make things easier for myself, but I don't want to make things miserable for the patients along the way. So,
thank you. There was a question in the chat that I think Tami has referenced, and Jesse as well, around sharing the BMT and Heme-Onc order set. So Mary, if you can put your contact information or share your contact information with our presenters, they've said that they would be happy to share that with you.
Thanks, I put it there in the chat.
Oh, perfect. Great. Sorry. I'm sorry. I didn't scroll down far enough. So, okay. So we're kind of closing out on time. Does anyone have any additional questions for the group? With that, I did accidentally not advance to this slide. So team, is there anything any additional comments you'd like to make as it relates to lessons learned?
No, I think that slide was right. So we all know we're all here, we're all involved in sepsis, and it's hard, right? It's very gray. It crosses many areas in all of our hospitals. We have novice teams that are working very hard in high capacity areas. So we're working on our resiliency and our teamwork, because we're dealing with a lot of difficulties every day. And really, we need to engage and collaborate with these teams that are working so hard. And so really thinking about how we can keep them the center, and really thinking about frequently refocusing on our goals as we learn from our teams and how we help move this work forward to help improve the outcomes for all of our patients that we're serving.
Thank you. Well, we appreciate your presentation today. I'm going to make a note and have you come back in 3 years so that you can share again all of the other cool things that you've been doing since then. But just as we close out today, I did want to highlight some upcoming MVC events. Next week, next Wednesday, we are hosting another Health in Action work group, and that will be with our CQI colleague called My Mind, in recognition of Suicide Prevention Month. And Kathy Frank, who is the program director for My Mind, will be presenting at that session. In addition, we have scheduled a report review webinar for MVC's new ED episodes-based report. So that's taking place on Tuesday, September 26th at 2 p.m. Presenters will include Kristen Hassett from the Michigan Value Collaborative, along with Keith Coker, who is the medical director for MEDIC, which is the emergency department-based CQI. We also have Alex Peel from the University of Michigan, who's going to be presenting at our Health Equity Work Group on October 3rd. And she will be talking about a validated social determinants of health screening tool that they've been using in the obstetrics world that can be kind of expanded to other patient populations. And then finally, MVC's Fall Collaborative Wide Meeting is taking place on October 20th in Lansing, Michigan from 10 a.m. to 3 p.m. So we hope to see folks at those events. Again, thanks everyone for joining today. Thank you to Tami and Carly and Rosalie and Jesse and Sarah for presenting from the Michigan Medicine team. If you have any questions or need anything, please don't hesitate to reach out to the MVC team. And Karen, I can add I see your note about the registration links. I can add it in the chat right now. And then I will also, yes, my pleasure. I will also include it in the follow-up email that goes out to everyone who's registered. But if you are ever curious about MVC events that are coming up, you can visit our website, which is michiganvalue.org. And I just dropped it in the chat.
Excellent.
Great. Thank you all so much. Take care.